Hi, we're here at the 2023 AATS Mitral Conclave. I'm thrilled to be joined by Mike Reardon. Mike, good to see you.
Great to be here, Randy. Thank you for having me.
Thank you. You know, you and I have spent a lot of airtime with each other, but it's good to see you in person. Good to see you in person. So I wanted to talk to you about the transcatheter mitral valve replacement.
Yeah.
You're deeply involved in one of the trials, the APOLLO trial. You're learning a lot.
Yeah.
Okay, a lot.
Yeah.
Tell me what your thoughts are right now about it.
Well, I think there's several things we've all learned. First of all, this was a lot more complex than we thought it was going to be. This is not a TAVR of the mitral valve. It's a much more complex valve and a much more complex delivery. Number two, we know we can eliminate mitral regurgitation, not just reduce it, but eliminate it. Our big issues so far have been safety. LVOT obstruction, the original devices are all transapical. They've got to be transseptal. They've got to be safe. If we can make this safe, reproducible, then this will really be a competitive therapy.
And obviously it started with the concept of the TEER sort of concept paved the way that you could do a transcatheter procedure. And I think you're right, the transapical was a tour de force for the patient and the operator. What have you learned, because you've been very actively involved in this trial and looking at hundreds and hundreds of patients, what have you learned so far that gives you encouragement? Let's put it that way.
Well, I tell you, I learned a couple things. Early on, I learned that we thought of the transapical as being a mitral valve replacement off pump. Well, just eliminating the pump doesn't help you that much. A hole in the chest, hole in the heart is still bad. Number two, we're doing transseptal transvenous right now. It's a world of difference physiologically. We used to send the transapical to the ICU. These people go to the recovery room. You go by and see them in the evening, they're asking when they can go home. And I think that we've learned that in the appropriate patients, we can do this, we can do it safely. We still need better engineering. We still need to refine the procedure.
The interesting thing is the LV outflow tract obstruction and MAC and all those things. Where are we with that?
Well, you know, we're constantly learning about how to predict LVOT obstruction.
Right.
And we're getting better, but we're not completely there yet. We still see some people that we think will be great, and they get it, and some people we think are borderline, and they do super. They have no obstruction whatsoever. And I think that's still a learning thing for all of us. But even as we learn, we still need to re-engineer our valves to take up less space. We need cutting devices for the anterior lead. There are going to be procedural refinements we're going to see in the next 5 years that are going to move along. Our original protocol in the Intrepid trial for the transseptal called for venous cut down. We're now going to amend it to allow percutaneous access. I think as a cardiologist, you know, people don't want cuts of any kind. They want everything percutaneous, and that's the ultimate goal.
Yeah. Mike, the other thing and certainly the MAC has certainly been an interesting concept, but the right side becomes incredibly important in everything we do. But I mean, when you look at the TEER data, if you've got bad TR, but it's the bad ventricle that really worries you. I mean, do you get a better feel for how to approach those patients who you're worried about?
Well, yeah, you know, I talk to you about this every week on the screening calls. And I think one of the hardest things for us to do is how do you predict when an RV is so bad that it's knocking it better? I think the learning thing there is we need to treat the people earlier. We're waiting till they've gone from, you know, maybe a little valvular problem to left atrial problem to PA problem to RV problem. By the time they get to the RV problem and have bad TR, we're over the hill.
Right.
And predicting how far over the hill is really challenging. I can tell you when they have a good RV, and I can tell you when they have a burnout RV. Yeah. But in the middle, it starts to get a little hazy.
The thing that's traumatic to me is this. I was a firm believer in a good mitral valve repair that has no MR. Leaving the OR is a really good. We do learn that these valves, they come out with no MR.
Yeah.
And so even if you've got a dilated ventricle, now if you treat them medically, then you can remodel the ventricle.
Yeah.
So that's pretty impressive to me that you can abolish MR in these patients who are difficult.
Yeah. Well, we've seen that over and over again. I mean, even when I look at the trials where we randomize mitral repair versus mitral valve replacement and functional MR, you know, the problem with our repairs is a lot of them recurred. But those that didn't recur were the ones that did so outstandingly well. And so if we can get rid of MR and we can do that safely, that's clearly going to be best for patients.
What's the role of the surgeon in the future in transcatheter mitral valve replacement?
Well, I hope surgeons stay deeply involved in this for a lot of reasons. Number one, there's those of us that have spent 40 years studying the mitral valve.
And operating
on it. We have a lot of knowledge, and I think that we can help our cardiology colleagues as we move through this. I also think that from time to time there are disasters that need to be approached very rapidly, both technically and in the decision-making process. And then I think when you have heart teams where surgeons are actively involved, these things happen faster and they happen better. I think all the really great places have an integrated surgeon.
if you looked out 5 years from now, 10 years from now, what do you think of mitral procedures that are done? What percentage will be transcatheter replacement versus TEER versus surgery?
Well, I think TEER is still going to lead because of safety. I mean, it's really hard to do that. I mean, we do TEERs every week. In our way, we go for functional MR, we look at them, and if we're thinking about doing something, it's TEER first. And if they fail TEER, then we think about TMVR. I do ever think there's other therapies coming along with neocortical papillary muscles. There's some exciting therapies besides just TMVR that I think you and I are going to live long enough to see come to fruition.
The obvious thing for young surgeons is you're going to take my job away. Is this taking their job away?
No, I tell you, my young surgeons still have more to do than they can get done every day. I do think that some of the work they do is getting more complex.
Right.
I lived through the early stints. I was told I was going to be out of a job. I've not been out of a job. It's not going away. And in fact, if you look at TAVR, we've created a whole new disease for surgeons, and that's called TAVR explant.
It's a disease.
Yeah.
They're not that.
Yeah.
No, I think it's true. But I compliment you, though, because this is really a very important trial. It's well thought out, and certainly you really are getting some tremendous learning from it.
Yeah.
So you're very optimistic about
I'm very
transcatheter mitral replacement in the future.
I am, Randy. We've done over 100 transvenous, transseptal repairs now. And again, having done my own and watched other ones, it is a world of difference. Right now, it's kind of like a MitraClip on steroids.
Right.
When we can make it like a MitraClip but with no MR, then we've got a winner.
Really good.
Yeah. And we'll get there.
Thanks for joining me, and thanks for helping out in this trial.
Well, listen, it's always my pleasure, and I learn something every time I talk to you. Thank you.
Thank you for joining us. Exciting times in mitral valve repair and surgery.